In this section, we're going to be taking a look at the concept of thermoregulation in relationship to hypothermia. These are the objectives for this section, and we will be taking a look at the student learning outcomes of providing safe, patient-centered, evidence-based nursing care for chronic and vulnerable populations, guided by the Caritas philosophy, specifically looking at evidence-based knowledge in health promotion, demonstrating critical thinking and clinical reasoning when providing quality patient care in community-based settings, communicating effectively with patients, families, and members of the interprofessional team. We are going to take a look at developing a teaching plan for a group of individuals at risk for hypothermia. And then lastly, managing care for clients and groups in diverse settings and collaborating with professionals to meet clients' needs. In taking a look at the definition of hypothermia, it is when the core body temperature is below the lower limit of normal. And normal is 36 and above degrees Celsius. So anything below 36 degrees Celsius would be considered hypothermic. There are several causes of hypothermia. There is either excessive heat loss from the body, there's inadequate heat production to counter the heat loss, or there's impaired hypothalamic thermoregulation. And if you remember, the hypothalamus is actually the center that controls the core body temperature. So if there's any injury or insult into that area of the brain, individual will have difficulty with thermoregulatory processes. As you can see, hypothermia is clinically relevant, especially when we are dealing with vulnerable individuals that are exposed to the elements. And as it's listed, the CDC actually does state that all hypothermia deaths are preventable. In taking a look at the pathophysiology of hypothermia, there are two different types. There is induced and accidental. Induced hypothermia is medically induced, and this is to preserve function. One case is within the last several years, they have started, after an MI, to induce hypothermia in an individual because it decreases the oxygen demand and need. So there's actually more perfusion to the cardiac tissue, and there is an increased survival rate and increased function of that cardiac tissue because of that. So that's an example of an induced hypothermic state. However, in this course, we're mainly going to be taking a look at accidental hypothermic conditions because we're looking at the vulnerable patient. And with accidental, this is mainly exposure to cold environments. The textbook references immersion in cold water, which is not particularly going to affect this course unless you're taking a look at the vulnerable patient in the cold temperatures and snow. Their sock shoes are wet, and they have exposure to wet clothing. But then also lack of adequate clothing, shelter, and heat. And again, that is going to be the clients that we are going to be dealing with in this particular course. So in frostbite, you need to have a basic understanding and what are some of the signs and symptoms so you will be able to recognize and also to educate. So frostbite is actually an injury to the skin resulting from freezing, and what ends up happening is if it's just a limited exposure, it's mainly your skin and subcutaneous tissue that's going to be affected. But with intensity of temperatures or prolonged exposure, you can actually go into the deeper structures that are going to be freezing. So most commonly, frostbite is going to affect the outer extremities, anything exposed to the temperatures, the face, fingers, and toes. And as the skin and subcutaneous tissue freezes, it will actually cause vasoconstriction. And this vasoconstriction, because the body is actually trying to warm itself, and the outer extremities, the body recognizes that that is more cold than the core body temperature. So it actually causes that vasoconstriction because it doesn't want the body to cool down even more. And with that vasoconstriction, it will actually cause infarction and necrosis of the tissue because there's no perfusion there. Some of the first signs of frostbite are numbness, itching, and prickling, and then the skin can become cyanotic, pale, reddened, and white from that lack of perfusion. And then as frostbite continues and progresses, the extremities or the area will actually become stiff and experience paresthesia, where there's not the feeling isn't there. And then there actually could be edema, blisters, necrosis, and it can become gangrenous. So it can actually result in an amputation. So we're going to take a look at the risk factors across the lifespan. And with infants and young children, the risk is that they do not have as much subcutaneous tissue and thermoregulatory processes that they are able to self-regulate their own body temperatures. So education as far as proper infant protection and swaddling, wrapping, extra layers of clothing would be important for parents to be educated about. Adolescents are at risk because they usually will engage in more risk-taking behaviors. They do not properly clothe themselves in the colder temperatures, and then they have prolonged exposure to the elements. Older adults are more vulnerable because they actually have their thermoregulatory system is not able to regulate as well in the extremes of body temperature. They have decreased subcutaneous tissue as well as actually redistributed. They actually have decreased metabolic rate, so it will lower their body temperature as well. And then older adults also are at risk for hypothyroidism, So, and that actually puts them at higher risk for not being able to regulate because it's a decreased metabolic rate. Also, the vulnerable patients, again, in relationship to this course, is they do not have the adequate resources. So, inadequate clothing, malnutrition, lack of shelter, food, and the availability of hats and gloves and scarves and warm coats, boots. So they may be wearing tennis shoes in 3 feet of snow, and these are the individuals that will have frostbite because their socks are wet and they're exposed to the elements for long periods of time. The other risk factors are alcohol, drug, and substance abuse because it actually will decrease their alertness to outside weather temperatures. And also trauma, the prolonged exposure to outdoor cold temperatures, endocrine disorders with the hypothyroidism, any kind of neurological impairment is going to affect because anything that is going to impair the functioning of the hypothalamus to regulate that core body temperature. So you can have an individual that has several risk factors as well. So you need to be aware of all of the risk factors. With the clinical manifestations, I do want you to take a look at your textbook, page 1439. Under clinical manifestations, you'll see the different categories of mild, moderate, and severe. So with mild, you're going to be having more cognitive functions that are going to be impaired. So you're going to have more slurring speech, inability to process information, inappropriate behavior. When you go into moderate hypothermia, you're going to be having more of your vital signs being affected. So everything is going to start to continue to slow down. So you're going to have lower respirations, lower heart rate, and lower blood pressure. And then with profound, you will actually have more further decompensation. So you can actually have an absence of respirations and pulse, and it will eventually lead to death. So anything, again, below that 28 degrees, they're at severe risk for death. With the nursing process, you want to make sure that you're able to accurately assess a patient with hypothermia. What are the signs and symptoms that you're going to be looking for? As far as diagnosis, what nursing diagnoses do you think would be the priority? There's a couple listed in your textbook, but see if you can think of some other ones that may be of significance. In planning, your prevention is going to be the primary nursing goal, which we're going to be talking about on the next slide as far as interventions. And then implement your plan. You want to make sure that you rewarm an individual. So that's going to be different in the community setting versus in an inpatient setting. In the community setting, it's going to be focused more on primary prevention and then what to do in the event that they do start to experience hypothermia. Inpatient, you have more resources, so you can use hypothermia blankets, you can use warm IV fluids. A little bit different, it could be much more aggressive. In evaluation, again, you want to make sure that whatever you're planning and implementing is going to be effective for that particular individual. With collaborative interventions, education is going to be the primary source of prevention. So a lot of education is going to need to go into the community with individuals and families, making sure that they have the resources that they need as far as appropriate clothing and shelter, and if not, coordinating efforts in their community to see what is available and if they're willing to utilize those resources. And then also education as to the signs and symptoms of frostbite and early warning signs and what to do. So in the community setting, if they notice that fingertips are starting to get a little numb, a little itching, a little redness, then they're going to want to make sure that they try to warm them as quickly as possible. And a very effective way for a vulnerable patient is to actually put their hands in their axilla. It will get more towards the core body temperature and it will warm that area up. If they do have any wet clothing, particularly on their feet, it needs to be removed immediately and dry clothing applied. So maybe suggesting that they have an extra pair of socks with them if they are not going to be able to wear boots, to make sure that they have dry clothing on. And then the inpatient care was previously mentioned just briefly on the previous slide, and that's using, of course, a lot more resources than may be available to that vulnerable patient. So those rewarming blankets, the hypothermia blankets, also education as far as any patient that we do not want to rub or massage the areas, and also in the community to let them know that they cannot apply snow to any area that's in question of frostbite. It will, of course, make the situation worse, but sometimes the thought is that that will actually help, and we need to discredit that. And then making sure that we provide that supportive care in the event that severe frostbite and gangrene blisters was incurred, and handling that for the patient as well.